All right, Dr. Eaton-Lupas, thanks so much for being here on this podcast. My first question that I want to start off with is how you a little bit about your background and how you started in the work that you do today.
Yeah. As you said, thank you so much for having me. My name is Dr. Andy Eaton-Lupas, and I am a psychologist and a board certified behavior analyst, and now a business owner running my private practice called Small Steps Clinic. Let's see, I started in this area in large part, probably I started at 10 years old, as an unpaid employee of my parents, providing care to my youngest brother, Kevin. He's got Down syndrome and autism. And for a lot of my childhood, I ended up being is part of his caregiving team and caretaking team and doing a lot of babysitting, but then also attending IEP meetings with my mom or special education meetings and advocating for him in that way. And then in other small ways, really spending a lot of time with him and like an older sister will, being kind of annoyed that I had to feed him all the time and take him to the bathroom all the time. And so really encouraging him to be more independent in a lot of those skills and use the toilet more by himself and feed himself more as an older sibling, often shirking their responsibilities as ought to do, but then also working on building other skills like saying my name, which to this day, and he's 22 and otherwise nonverbal, but my name is the only thing he's ever reliably said before. And so a lot of adults would see this and see how much we got along. And we're like, oh gosh, Andrea, like you should be a special education teacher. But because of my own sensory sensitivities and my desire to not be in a chaotic classroom setting, I was like, oh, no, not for me. But then ended up still working in this area and was at a special recreation camp, working as a camp counselor, which to this day I will say is like the best job I've ever had. Because it was just having fun with kids with developmental disabilities at this day camp and got to work in a one-to-one setting. And in that, I was working alongside one summer with a school counselor who's like, "Oh, you can totally do this work one-to-one. It's not just a special education teacher or nothing." And that led me to the field of school psychology and doing that type of work in grad school and in a doctoral program, and then moving towards outpatient clinics in the hospital setting, where I was most recently at Seattle Children's before starting my private practice.
That's a really kind of a unique sort of journey. Yeah.
Yeah, yeah. And like it's really informed like that this is where I ought to be and where I want to be and where I love to be.
hmm What's it like doing your own private practice?
It's so different from the hospital. So this is brand new to me as of the last month or two. And there's perks and drawbacks to working in either setting. One huge one is just that I am setting my own schedule and sort of deciding when I get to see patients, and also if I need to step out for my own medical appointment, I just have more flexibility. And doing that and just a lot more authority and agency and an ability to do things that I feel like, okay, this is how I was clinically trained to the gold standard, and so this is how I'm going to do it. Where in a hospital setting, there's a lot more rules and permission that you need to be requesting, and a lot more focus on making the business um, sustainable and financially viable and all these things that are tricky in a big, big, big hospital setting where there's miscommunication and a lot of rules. In a private practice, I still get to follow the evidence basis, but I get to do sort of purely what I was taught to do and what I was trained to do, rather than sort of what insurance will dictate you need to do to jump through hoops and get reimbursement. And so that's been really freeing as well.
What do you do now in your private practice? Do you work with people who are with Down syndrome? Because you said you had a brother that has Down syndrome. Is that like your main population, or is there something else within the disability realm that you work
Yeah.
with?
So across definitely Down syndrome, but across the intellectual disability and autism um, patient populations. So kids often with neurodiversity, things like autism and intellectual disability, and doing both treatment and diagnostics. So the diagnostic arm is really meant to evaluate for autism, and in doing so, giving assessments and interviews to try to better understand, is this autism? Is this maybe actually an intellectual disability, or is it both? Is it ADHD? Is it anxiety? Because good autism evaluations oftentimes will look at other possible diagnoses and rule those in or rule those out. So that's sort of the that arm, and then the treatment arm is really providing good mental and behavioral health care for kids with intellectual disabilities and or autism. So really providing support for those kids who have also got things like anxiety or OCD, who maybe have sleep disorders that are more behaviorally linked. Kids with skill teaching needs, so things like learning how to shower independently or toilet independently or get dressed independently and really just foster that and foster some self-advocacy skills as well. So teaching functional communication, well, that's usually in the space of things like aggression or self-injury, where kids are trying to communicate something, but trying to give them, as a clinician and working with their caregivers, a safer way to communicate that want or need, recognizing that that behavior is communication, but that the way they're communicating right now is maybe not safe for them or for their family or classmates. So a lot of different behavioral and mental health needs, but a lot of that is also working with parents and teaching them how to apply the skill for their kids across different settings. So it's not just me in our clinical space.
What sorts of modalities do you use when working with this population?
Yeah, so a lot of it is cognitive behavioral. I am first and foremost, I'm a psychologist, but I'm also trained as a board certified behavior analyst. So I will also apply more just pure behavioral strategies. But a lot of what I do is cognitive behavioral. So, for example, exposure with response prevention is a really good evidence-based means of care for things like anxiety and OCD, and doing a modified version of that for kids with autism or intellectual disability to be working on and treating those. Um, would it be helpful to go into an example of that?
Yeah, an example would be nice.
Yeah. So for one kid, actually, I'd met this patient in a severe behavior clinic. So the initial concern had been really aggression and self-injury, and after more assessment and understanding of it, it had turned out it was really a fear of the bathroom. Like it was whenever he had to go to the bathroom that he got very aggressive or disruptive. Um, and so it turned into a lot of our exposure steps. We ended up breaking it down, and we didn't do this from the outset, but we learned as we were progressing with him that it needed to be a lot of different broken down small steps, which is how my clinic name came to be. But it started out as just saying the word bathroom when he was around, and then um, looking at a picture of a bathroom and then walking by a bathroom with a door closed, walking by with a door open, going in for a second and leaving, going in for 5 seconds and leaving, going in for 10 seconds, leaving, going in for a minute with the door open and then with the door closed, and eventually moving closer and closer to the toilet to where he was eventually sitting on the toilet with his clothes on and then actually using the toilet. And after got really, really good at that in our clinical setting, transferring that to the home setting and practicing that with him at home to where he started feeling really good and confident. But layered into that was what we didn't know was that this actually was a really big trauma response. It was initially interpreted as this like refusal and resistance to use the bathroom, but it was really because he had broken his foot while showering at some point, and nobody had known for weeks that that had happened. His
Mm.
communication and the communication of his care providers and his family weren't meshing, so they were not understanding that he was actually in really significant pain for a long time, and that's why he was refusing the bathroom, because his foot was broken, and because this had become associated with that break and that lack of care. Um, or medical care, I should say. His family definitely cared about him, but didn't know that this was a medical thing to be treating. And so he had also been ambulatory at that point. He had been walking, and after the foot break, he had stopped walking and started really relying on a wheelchair. So, unbeknownst to us, and after consulting with his physical therapist, who were very much like, well, we can't work with him because he's refusing to work, we had approached him more again from that anxiety lens and broken it down of like, okay, we're going to give him the confidence to walk on his own again, which is a tricky tricky uphill downhill battle because he had some genetic syndromes that made him more predisposed to things like foot infections. So sometimes it was harder, but it was the anxiety piece and getting rid of the anxiety and breaking that down where we were able to be effective and have him be proud of himself and what he was accomplishing and not be scared of walking, but then also being able to say, like, no, when he started refusing again, this isn't just anxiety now. Like, we know it's pain again, and teaching him to advocate more in that pain. What is pain versus just fear?
Mm-hmm. And what like I know that I talked about modalities, but like how do you sort of help folks because you really give a good example of this kid, struggling to do that, but how do you sort of help, folks that are sort of struggling with that? How because teaching these kids, can be kind of difficult depending on the situation.
Mhm. Yeah, so a big part of it is going to be just finding something that doesn't, in good OCD or anxiety care, there's different modalities where you can do sort of a one session therapy where you just do it in a big way for many hours in a day. But then what I do oftentimes is just get the next level up or the next level of difficulty where it doesn't trigger those big feelings or escalated feelings, where the kid isn't kicking, crying, screaming, yelling, doing all of that, but just making it just a little bit harder to where they can still tolerate it. Um, and then also having a reinforcer in place. And this is where more of my board certified behavior analyst skills come in and really trying to figure out, okay, you maybe aren't internally motivated to do this. Let's see how we can make this more palatable. For example, for the kid where we had been working on the bathroom and then eventually walking again, his reinforcers were we always had a dance party to some of his favorite music, and I think it was music in Arabic too. So we had learned our versions of the Arabic words and the Arabic lyrics and danced around with mom and really just partied. And he really loved turkeys. So we also just made the activity more interesting. Like when he was stepping in the padded floor in our clinic, having there be turkeys on the ground and he had to step on the turkeys. So it was making the activity more fun and just doable, right? If he was refusing to do it, then we knew we had made it too difficult. But then the other piece was actually like not just fun during, but fun after. Like he got to work towards something that he was super excited about.
Mm-hmm. And so which gets me to my next question for like folks with like this kid or for those who have other, struggles, how do you sort of help them through that? Because not every kid is the same, each kid is
Yeah.
different. So like because oftentimes depending on what conditions or situations they have, it you kind of have to do some picking and choosing. You kind of have to modify based on,
Yeah.
their needs. So like how do you as a clinician do that?
Yes. So a big part of that is partnership with caregivers and because me and the child sometimes won't have the same communication pattern. I'm super verbal and a lot of my kids aren't. And it's working with caregivers to find out, okay, what does your kid really love? Where are you seeing them struggle? And individualizing it to that child and in their own idiosyncratic interests. Like none of my two therapies look the same because my kids two different kids interests aren't going to be the same. So individualization of care is a huge thing, and then also taking good data to say like yes, this is working, or no, this isn't changing anything, or actually this might be making things worse. So actually showing that, because sometimes the progress is slow or limited, but it's progress, and sometimes you feel like, oh gosh, like we haven't made a difference. But really, what happened is that you had a bad day yesterday, right before our appointment, and the whole last week, actually, they're doing better and better. So taking data to just see what progress we're making, and if it is progress, but then also individualizing it to each kid, um, going faster or slower based on how they're doing and how they're assenting, and if they're this term of happy, relaxed, and engaged in care, and really being mindful of their own interest and their own progress, and as much as we can, um, pulling in what they're motivated to do. A lot of my kids don't see a reason to resolve their anxiety or OCD or other bigger behaviors, or it's too hard or it's insurmountable. Um, but But if we're breaking it down in small ways, if we're making it more engaging, if we're reinforcing and sort of starting that, one of my supervisors used to call it like it's like starting a lawnmower. Like you're putting in a lot of effort, you're putting in this external reinforcement,
Mm-hmm.
but once you got it going, you've got it going. And so once kids are more internally motivated, and some kids get there, some kids don't. But then we pull back on that external reinforcement, and then we sort of just make it into the routine, because all of a sudden it's not as scary anymore.
Mm-hmm. I want to ask this other question, like what about the parents? Because from the parents' perspective, they're like, I want my kid to advance, progress,
Yeah.
progress, progress, but then the kid has certain conditions that impede or limit his how much he or she can progress. So how do you sort of work with the parents that that are in that sort of
Yeah,
headspace?
yeah. To where their goals are maybe more than what the child can achieve in that
Yeah,
moment. Yeah.
exactly.
That's a tricky one because I also never want to limit what hopes that a parent has for their kid. Right, because you hear all those stories of like, well, the doctor said we never be able to do this, and now look at him, look at what they can do. But a big part of it is like, okay, so this is the goal, and if say one of the goals is completely living independently, and this child relies on 24/7 caregiving support and there may be 12, and we know that like that distance is going to not be reached, we'll talk about like, well, maybe they don't have to live at home, maybe they can live in a residential placement with other peers, so they have more of that independence from caregivers, and that they're still well supported in their care. But in other ways, what I'll tell parents is like, okay, we can work towards this goal, and in order to get towards that goal, what is a small way we can move towards that now? I'm never going to say that a kid can't reach something. And I want to be super soft and caring towards caregivers. But more often than not, I feel like they do generally have a realistic assessment of their child as they get older or start seeing me. I think the bigger thing is sometimes in diagnostics is when a kid is so young, I don't have the crystal ball of how well they're going to do or not going to do in the future. Really, only if a child has a really significantly limiting intellectual disability do we know that, like, maybe full independence won't be possible, but there's different ways we can get to what the parent is really hoping for their goals in a way that is still properly supporting the kid.
Mm-hmm.
If that made sense.
Yeah, that does make sense. Because oftentimes, it can be hard for these people, right? So yeah, so it's like trial and error, like seeing how a person progresses, and yeah.
Yeah. Yeah, yeah,
Um, my next question is like, what have you learned in doing this kind of work?
yeah. Um, let's see. I think one thing that I've learned a lot is just how involved parents need to be in, or caregivers need to be in good care. I definitely had started as a child psychologist because I was like, well, I don't want to listen to adults complain. I'd way rather play with kids and like get in early when we can have the most life change. But what I didn't realize is actually what working with kids means is if you're going to change their lives, you're going to work with their parents to change their lives because that's who's with them 24/7 most of the time, or who's going to be there the majority of the time. It's not going to be me. And I tell parents all the time that, well, like I can get them doing well in my clinic. I can get them being brave and safe and regulated. But that's going to be 1 hour a week that they do this with Dr. Andy, and that's not going to be as helpful at home or with you or in the community. And so we really need to bring parents in, and so, parent involvement is a big, big piece of coaching caregivers and bringing them in, and really also being compassionate and warm for caregivers because they're working hard. And oftentimes, in a lot of the therapy I do, um, the parents are working just as hard as the kid to change. And to change their behavior and to help their child, and they do it out of a lot of love. So having a good therapeutic alliance, not just, which is a very psych term of like just building a good relationship with your patient, applies to
Hmm.
not just the kid, right? I definitely want the kid to like me and to get along with me, and that's the part of my job that I love the best. But building this good therapeutic alliance with the caregiver and having unconditional positive regard for them, and knowing that like if they're saying like they can't do something, well, I could be giving them the most evidence-based, best intervention in the world, but if they can't do it, then it's a terrible intervention, because I'm just there to make them feel guilty. So really, parent partnership is is a big, big part of what surprised me in this.
Mm-hmm. And I see that you have a bookshelf there. So what
Yeah.
kind of books do you recommend to people that, that are in the situations of like, because we talked about people
Ooh,
with autism and Down syndrome.
yeah. What's Mm, I won't say funny, but what's interesting is that so many of the books, I feel like I used to give out so many more book recommendations when I first started, and then I ended up feeling like I was just guilting parents into reading more and doing more. So more often than not, what I end up doing is actually being like, "Hey, there's this like recorded class that you can attend or go to or watch on YouTube." So more often than not, it's that. Um, I'm trying to think of layperson books that I've read or recommended. Like I have lists and a lot of like different behavioral texts. And of course the names are not coming to mind right now. But more often than not, I think my own behavior has been punished. And that when I get it, parents are like, oh yeah, yeah, yeah. But like what can we actually be doing or what is a quicker digestible one? Because I definitely like used to do a lot more like there's a book about the early start Denver model where I was like, this is the most amazing book and every parent should read it. And what I realized is parents oftentimes are so busy or so overwhelmed that whatever we can do to give a actual practice or synthesis of it or like an audiobook version of it or an audio or a podcast even so like what you're doing I'm oftentimes more referring families to um, than books at this point which I don't think I'd realized until now because I'm a
Yeah,
big reader.
yeah, yeah. Reading books is good, which is something that I have fallen back recently. Which I should do more. Yeah,
But see, that's a big thing. I don't want you to feel guilty for not doing or shoulding yourself, as one provider I've worked with has said. Like I want it to be an easy thing, and I know parents are just inundated.
yeah. My next question is, what is there something new that you want to learn in like in the mental health space that you're like, I want to
Yeah,
I haven't thought about this or would like to look into this a bit more.
yeah. I think things I'm doing deeper dives on are just how to adapt and modify a lot of cognitive behavioral strategies for kids with intellectual disabilities. Um, and that's something I'm already doing a lot of. I think more good depression treatment training, I'm definitely doing a deeper dive on right now because there's not really a whole lot out there. And I think that's what's tricky is when there really isn't an evidence basis or not a big one. There's some evidence basis for how to adapt treatment for depression for adults with intellectual disabilities, but less so for kids. And as I'm learning, many of my teens end up having depressive features, and so I've adapted some of the behavioral activation work that I've done before, training that I've done, but really trying to do a deeper dive on that. There's also increasing talk about pathological or a pervasive demand avoidance or PDA profile in autism. So wanting to learn more about that because that's also not a super well researched. It's very well proposed as a theory and a profile type in autism. But right now that research isn't there, and we have the research on good behavioral treatment, and a lot of advocates are saying like, no, that's not what's most effective. But balancing that with what they are claiming is effective oftentimes is avoidance, and avoidance can foster more anxiety and make the anxiety worse. So wanting to be really thoughtful and diving into those types of things.
Lastly, what tips and advice would you give to those who are want to study what you're doing?
Yeah. Um, I would say probably to actually do some of the work before you get too invested. I think grad school is such a beast, and I don't know that I would recommend it to a lot of people after having gone through it. Like I'm so grateful for my doctoral program and all the things I learned. And you can be a mental health practitioner without the PhD, right? You can do a master's level degree, and I would say folks can do things like work like as a behavior technician or as support in a mental health clinic. Um, and really working on focusing in those spaces in clinics that serve kids with intellectual disabilities. But beyond that, also thinking if you want to do more of that diagnostic and assessment stuff, that does oftentimes, especially if you want to focus on autism, require the PhD. So doing things like working as a psychometrist, which is a support person. So somebody that I could hire as a psychologist who would help administer the testing. It would still be me as a psychologist interpreting it, but as a psychometrist helping deliver the assessments, you would get some really like good firsthand experience in doing it. Because I will say, like, this job gives me a lot of joy. And I hear from people all the time being like, oh gosh, I could never do what you do. And I'm like, well, I can never do what you do sitting behind a desk and just doing numbers all day. Like, that would be dull to me. So, really, seeing if you've got the heart for it, but then also the like that it gives you joy and is something that is sustainable. Like I know when I first actually got out of grad school and started working in this area, I was like, oh gosh, like I'm so scared to go to work on Monday. And then Monday would show up and I'd be like, oh my gosh, I have the best job in the world. Increasingly though, I realized like I really like in-person care. Virtual care is a little tougher because kids aren't as engaged on Zoom, which makes sense. But really thoughtfully doing some of the work at even just the bachelor's level, seeing if you like it, if this is sustainable, if it gives you joy, and then pursuing it. Because this is a field that can easily burn you out. So being able
Yes.
um, to thoughtfully enter it and know that like, okay, if 1 year in this isn't draining, if it's joy giving or life giving, being super thoughtful and being like, okay, then I think I'm gonna do this.
Mm-hmm. Alrighty.